Hi, everyone. Welcome to our Monday Night IBD program, Improving Clinical Outcomes and Patient Satisfaction in Ulcerative Colitis. I'm Dr. Aline Charabaty at Johns Hopkins, Washington, D.C., and I'm joined today by my colleagues and good friends, Dr. Maia Kayal and Dr. Alan Moss. Dr. Kayal, you want to introduce yourself?
Sure. Thank you, Aline. And I'm really excited to be here with both of you. I'm Maia Kayal. I'm an assistant professor of medicine in the Division of Gastroenterology at Icahn School of Medicine at Mount Sinai with a focus on inflammatory bowel disease and pouch disorders.
Welcome, Maia. Thank you for being with us. Alan?
Yeah, thank you, Aline. So I'm the professor of medicine at Boston University and director of the Crohn's and Colitis program at Boston Medical Center. And I'm also excited to be here this morning with you guys.
Fantastic. Our faculty disclosures are displayed on the screen. And let's start our program. Our program today is the first of 3 live stream programs about improving management of patients with ulcerative colitis. We'll have another live stream next Saturday morning, November 21st, and a third one in January. If you haven't done so already, please make sure to check out the tutorial that Dr. Alan Moss posted earlier this week on Monday under the Monday Night IBD Twitter handle, and keep an eye out for another tutorial this coming Monday from Dr. Anita Afzali. During today's program, please be sure to comment, tweet, ask us questions on our live Q&A session at the and we'll go over these questions during our live Q&A session at the end of the program. So during today's program, we will be addressing the following learning objectives: apply safety and efficacy data from clinical trials and real-world studies of new and emerging agents to achieve an individualized, patient-centered approach to UC management, interpret the updated UC guidelines to improve treatment decision-making and care for patients, and evaluate potential approach for positioning new and emerging therapies for UC, and describe clinical situation in which novel therapies may be advantageous for patients with complex inflammatory bowel disease. Today's program is going to focus on 3 different patient cases. Our first case will cover a patient with UC and extraintestinal manifestation. Her name is Amanda, and I will start this morning with Amanda. All right. Let's meet Amanda. Amanda is a 41-year-old woman. She has a history of uveitis, and she was diagnosed with moderate to severe ulcerative colitis, pancolitis, a year ago. She needed to be hospitalized, and she required infliximab that was started, and that put her in clinical remission. She's been on infliximab 5 milligram per kilogram every 8 weeks, doing well. But she presents now with a 2-week history of abdominal pain before bowel movement, multiple loose bowel movement during the day, and 1 nocturnal bowel movement. The bowel movement are urgent and associated with blood up to 30% of the time. She really complains also of fatigue. She can't sleep. She's waking up at night. She's not eating well. She lost 5 pounds, and she reports joint pain in the hand and ankles. Amanda is a very active woman. She's the mother of 2 children. She's a professional. She's a runner, and this active disease is really affecting her life. So when you see her on exam, her abdomen is mildly tender to palpation on the left side. Her right ankle is swollen and painful. Labs are sent and show increase in inflammatory markers. CRP, fecal calprotectin are both elevated. Her abdomen is holding at 3. Stool studies are sent, of course, and C. diff and stool studies come back negative. And you send a trough level. She's due for her infliximab in the next couple of weeks. And her infliximab level at this point is low at 3. And she has antibody to infliximab at 75, so elevated here. You set her up for a colonoscopy, and she has UC pancolitis, and her mucosa is granular with loss of normal vascular pattern, some superficial ulceration, no friability, and you assess her UC as being a Mayo score of 2. So what can we do for Amanda? So I think when we're approaching a patient with ulcerative colitis and management, it's important to assess few things. the disease activity, how the patient is doing now, the disease severity, what has been the historical course of this patient, and whether the patient is at high risk of colectomy. So let's talk first about the disease activity. How is the patient doing today? What are the GI symptoms, the extraintestinal symptoms? How is the patient living the disease? How the disease is affecting the patient life? Are they able to go to work, take care of their kids, take care of themselves? Are they able to have a normal life, or is the disease truly impacting their daily activities? So it's important to listen to what the patient is telling us in terms of how the disease is affecting their life, what we call patient-reported outcome. And also have an objective assessment of the disease activity. What's going on in terms of inflammatory markers, in terms of the endoscopic activity. And then look at the overall disease course, how this patient has been doing since diagnosis. How is the disease burden been on the patient? How often the patient needed to be hospitalized, needed steroids, etc. So really give us an overall view of the disease severity. And then assess whether or not the patient has a risk for colectomy. Younger patient with extensive colitis, ulcers on colonoscopy, patient who've been on and off steroids or cannot get off steroids, if the patient has been hospitalized in the past or had C. diff or CMV infection, all these are risk factor for the patient, put the patient at higher risk of colectomy, and we need to be very aggressive in how we approach their disease. So we assess the disease activity, the historic severity of the disease. Does the patient have risk for colectomy? Next is really to assess what are our treatment goals for that patient. So it's important to, of course, we want our patient to do well and to be in clinical remission. And it's important to keep in mind that clinical remission for a patient does not only mean GI symptoms, but also the extraintestinal manifestation, the joint pain, the skin lesions, if they're present, the uveitis, etc. So look at the whole picture, GI and outside the GI. But we know now that it's important not to only achieve clinical remission, but we want to achieve endoscopic healing to prevent further flare, hospitalization, needing for surgery, and disability. And using inflammatory biomarker like CRP and fecal calprotectin are good goals to assess indirectly endoscopic healing. So clinical remission, biomarker remission, endoscopic remission, preventing complication and disability, and allowing the patient to gain back their quality of life while minimizing any side effect from the medication. So with the disease assessment and the goals of therapy in mind, let's see what kind of therapies we have and what are the pros and cons and how we can find the right therapy for our patient. Next. So the AGA put out recently a clinical care pathway for the initial treatment of ulcerative colitis or for treatment in patients who fail or who do not respond to a first-line therapy. And the way this clinical pathway is designed is really by stratifying the patient in terms of risk of colectomy, low colectomy risk, high colectomy risk. So your low colectomy risk is your patient with mild UC. I think we all agree. We start on mesalamine, a combination of oral, topical, adding maybe some topical steroid. If this is not enough, a short course of prednisone until the mesalamine kick in. And if the patient does well, then maintaining on mesalamine and making sure we're tapering off steroid. Our patients seem to be more in the high colectomy risk outpatient, right? So this is a patient with moderate to severe disease. How do we start therapy? If this was a therapy naive patient, we really have a choice of all the therapies that we have available and that are effective. So whether starting a course of steroids along with thiopurine or vedolizumab, anti-TNF, ustekinumab, or tufasitinib. After the AGA guidelines were put out, we know now that tufasitinib is approved after failing or not responding to one of the other first-line therapy, mainly anti-TNF. And if the patient does not respond or lose response to one of these agents, then we go to the next step. And this is where our patient is at. And the next step really include a potpourri of all the effective therapies that we have. The patient can go to TOFA, anti-TNF, Vedo, thiopurine, etc. So how can we choose the right therapy for our patient here? So now that we have our treatment option, let's look at the treatment efficacy. Siddharth Singh and his colleagues did a network meta-analysis with the goal of looking at the relative efficacy of biologic and tufasitinib for the induction of remission in patients who are biologic naive or who have been exposed to anti-TNF in the past. And they looked at the data from randomized control trial of these therapies in moderate to severe UC and used a ranking system to assess what is the therapy that is most effective in biologic naive or anti-TNF exposed patient. So for biologic naive, the winner here is infliximab. In terms of endoscopic and clinical remission, infliximab ranked highest. After infliximab, vedolizumab, and tufasitinib also had a high ranking of endoscopic remission and clinical remission. And then ustekinumab, golimumab, adalimumab had a similar efficacy data. For a patient who's been exposed to anti-TNF, like our patient, the two agents that ranked highest in terms of clinical remission and endoscopic remission were ustekinumab and tufasitinib. So how are we going to choose our treatment? What is next for our patients? So it's important to remember now, when we look at a patient, we assess the disease severity and activity. We have the guidelines, how to proceed. We have our goals, and we have a ranking in terms of efficacy. But it's important to remember that, when we're looking at our patient, to have more of a 360 view. How can we apply all this knowledge to our patient who has GI symptoms, extraintestinal manifestation, with a history of uveitis, peripheral arthritis, who's now flaring, who has really, the flare is really affecting her quality of life and her capacity to take care of her kids and being at work. So it's important to recenter all that knowledge to our patient. So this is where I'm going to call my friends and ask them for help. What can we do with Amanda? Maia, can I start with you?
Sure. So I think this is a great case that highlights a lot of important aspects that we often see in our IBD patients. And I think in Amanda's case, what's really important to note is that she achieved good clinical remission with Remicade initially. And she had resolution of her GI symptoms and her extraintestinal manifestations. And I think what's important to realize is that you beautifully went through kind of the algorithm and the medications that we have available. But the truth is we still don't have that many medications available for IBD. So we really need to kind of work on salvaging the class and the mechanism of action for medications when a patient responds to it. So to me, that basically translates that this patient responded to an anti-TNF and did very well. She had secondary loss of response due to antibody development, but not necessarily due to mechanistic loss. And so for that reason, I would recommend that the patient would consider another anti-TNF, so adalimumab in her situation. She's active, as you had pointed out. She's a busy mother, as you and I are. She's constantly on the go. And so I think giving her the option of adalimumab would be great because it would give her ease of use and ease of maneuverability with her kids. But then we know that she responded to that class and to that mechanism of action. And so I'd hope to recapture her again with an anti-TNF.
I think you bring up a wonderful point, is looking at the past history of the patient, what did they respond to, but also looking at their preference. And that's something that's very important, the infusion, the injection, the practicality of things. Medication can be wonderful, but if the patient cannot take it, or it's not going to work. So adapting kind of our choice, as long as it's an effective choice, the patient lifestyle and preference, I think is very important. Alan, would you do something different? Do you agree with Maia? How would you approach this case?
So I actually really like Maia's thoughts of salvaging this class first. And I think her case brings up some interesting questions, right? She's got a trough of 3.2 with some ATIs. Could we salvage infliximab, right? Could we aim for a higher trough, add in immunomodulator, with those ATIs? The answer in my mind is we don't know where the cutoff of ATIs is beyond which you just can't salvage people. So that comes to mind. If she wants mucosal healing, we'd be aiming probably closer to 10. And we know that some of these patients have transient ATIs, and then the second time you measure them, that may not be as high. And if you can drive the trough higher, add an immunomodulator, you may be able to salvage her first drug. So that's a possibility. The second option, I agree, anti-TNF worked, so I would try and then maintain within class with something like adalimumab. I think once we go beyond that, what's the best for her lifestyle and her EIMs? I think she's used to Q8-week dosing. I think something like Ustekinumab would make sense for that from a lifestyle point of view, and maybe holding the JAK class as kind of plan C, if you like, because she's got evidence of mucosal disease. It's moderately active, so we're going to need to salvage her quickly and get her back into remission. And so they're the things that are going through my mind.
That's fantastic. I think we practice very similarly. I think it's important, like Maia pointed out, we do have different classes and different drugs, but it's important not to waste them and to go biologic or small molecules chopping one after the other. So I agree with you, Alan, that maybe optimizing what we have now, the dose of infliximab or frequency, adding an immunomodulator and see if we can recapture response is definitely one option. I agree with Maia that in this case of patient with gastrointestinal manifestation responded to anti-TNF, plan B would be adalimumab, and it's always important to have a plan C. So I think the approach here, I think what I'm hearing also that's very important when we're discussing with a patient is really to have that next step and that plan, and then discuss that with the patient and see how the patient feels about it. And I'm curious to know, Alan, why would you go next to Ustekinumab versus Tofa in this patient?
Yeah, so it's not from an efficacy point of view. I don't think we're going to expect a difference. It's more from a sustainability. If this is someone who's used to a Q8-week biologic, that's a natural progression versus going to a BID small molecule. So it's more to do with patient preference than either efficacy or safety. I think those are probably, in my mind, at this point, equal considerations, but the patient preference may drive what's going to be sustainable for her going forward.
Absolutely. Well, these were all great comments. So let's go back to our slide and see what we did with Amanda. All right, so I have to put a plug here for one of our fantastic IBD algorithm master, Jean Donnet, who actually asked Monday Night IBD team, well, how would you rank or how would you choose a therapy for a patient with ulcerative colitis? And everybody pitched in to help. And the next slide is a little bit of a summary of what came out of his call out for input, and really that is not meant to cover everything and all case scenarios, but it's really meant to make you think that it's important to look at the entire picture and then choose the therapy accordingly. So as somebody with diffuse extraintestinal manifestation, especially if there are extraintestinal manifestations that are independent of the disease activity, ankylosing spondylitis, pyoderma gangrenosum, uveitis, anti-TNF are a very good choice because of the efficacy for these extraintestinal manifestation. Somebody who value convenience or have limited time to be away for an infusion, think injectable, subcutaneous. We'll talk with Alan about how to choose the best therapy in elderly patient, keeping in mind safety. Somebody with a history of melanoma, lymphoma, we tend to consider Vedolizumab first as a gut-specific biologic, although it's important to keep in mind there's no evidence that other biologic that are more systemic, like anti-TNF or Ustekinumab, do increase the risk of recurrence of a prior malignancy. If there are associated conditions like rheumatoid arthritis, psoriatic arthritis, use an agent that works for both. Going back to our case, a loss of response to anti-TNF, either second anti-TNF with an immunomodulator to prevent the development of antibodies, or the choice to change mechanism of action depending on the overall context and clinical picture of the patient. And if somebody was a primary non-responder to anti-TNF, then change mechanism of action, again, taking into account the whole picture. Next, and I think what's important to remember, next slide, please, that this patient seemed to have done well with infliximab and kind of lost response until a year later when she came with a flare. So it's important to remember that monitoring the disease activity and treatment response is as important as choosing the right therapy for the patient. And monitoring includes clinical symptoms, but also biologic marker like CRP and fecal calprotectin, endoscopy, assessing adherence to therapy. And the frequency of this monitoring really can depend on whether this patient is at low risk of relapsing or high risk of relapsing. Of course, patients that are high risk of relapsing need monitoring more frequently, maybe every 3 months, versus those who are low risk, you can do an office visit and check labs every 6 to 12 months. Patients that are high risk are those who had flared within a year despite therapy, where there had been a recent change in their maintenance therapy, whether you change the dose and frequency or change mechanism of action or change the treatment plan. Those who have persistent endoscopic lesion or histological inflammation, patient with UC who just recently stopped smoking, and those who have a history of not being too adherent to therapy or follow-up, and the younger patient. So look at your patient as a whole, the disease activity, severity, prognosis. Have there been any recent change in therapy? Are we struggling to get them well? These are the patients you want to maintain a close follow-up, both clinically and by labs. So I'm just going to conclude with my slide to just remember to have a more 360 view of the patient with UC, looking at their GI symptoms, extraintestinal manifestations, their lifestyle, their reported outcome, their reported, what is the effect of the disease in their life, and really include the whole team when needed of GI, but also dermatologists, rheumatologists, nutritionists, radiologists, pathologists. Everyone should be involved in the care of patients with moderate to severe disease to improve outcomes. All right, on that, we're gonna shift gear and go to our next patient, Robert, with you, Alan. So I'm going to go over the case and then hand it to you.
Great.
This is going to focus mainly on managing UC in the elderly. Next. All right, so Alan, this is a patient who's 69. He had mild to moderate UC of the rectus sigmoid for 3 years now, and he's been doing well on mesalamine, oral mesalamine, and occasionally he needs some rectal mesalamine or budesonide for mild symptoms. He is retired, but still active and does consulting work. He babysits his grandkids 2 days a week. He's widowed and live alone, but has an active social life. He's overall pretty healthy. He has high blood pressure and high cholesterol, but they're controlled. And he had resected squamous cell carcinoma 5 years ago and get a frequent derm check. He comes to you because now his flare looks different than the usual minimal symptoms that he can control on his own with adding budesonide or topicals. And he's having 5 loose bowel movement per day with blood in half of them. He has urgency, tenesmus. He had episode of incontinence at night. He's losing weight, and this is really creating a lot of fatigue and really affecting his capacity to live his normal life. On lab, his CRP is elevated, his fecal calprotectin also at 350. Stool studies and C. diff are negative. His albumin is 3. He's slightly anemic with hemoglobin of 8. And on endoscopy, he has pancolitis with a Mayo score of 2. And you start him on prednisone, and he does very well on prednisone, but every time we try to taper below 20 milligrams, he has symptoms again. We recently had a conversation on managing elderly with a UC flare, led by Jason, who Houston, Texas, and people had divided, approach. Some people felt that budesonide would work. There were some that felt NF would help the patient, but most patients actually looked at Vedolizumab and Ustekinumab as a better option in patients with ulcerative colitis who are in the elderly age group. So I'm looking forward to hearing your thought, Alan. How would you approach this? Are Ustekinumab and Vedolizumab the better choice for our patients with UC above age 60?
Great. So thanks, Elaine, for sharing that with us. And also, thanks for asking me to talk about IBD in the over 60s. Is it because I've got a couple of gray hairs? I suspect that might be why. So next slide, please. So I think the Robert case illustrates a really important point for those of us looking after patients with IBDs. Typically, we really have, two balls to juggle. It's the patient and efficacy for the most part. But with patients who are older, we've got to juggle efficacy, safety, comorbid medications, comorbid illnesses, as well as trying to get the patient remission. So it's a far more complex scenario. We're starting to realize not only are we seeing more and more patients diagnosed over the age of 60 with IBD, our existing cohort of patients like you and I are also getting older, and they're developing new diagnoses independent of their IBD that has considerations for safety. And at a ballpark estimate, about a third of our overall patient population now is in the over 60s. So, and these considerations are really important for us, but they also should be important for payers in, trying to dictate what agents we use and how we use them. Next slide, please. So what challenges arise in the elderly population? So I think a couple of things come to mind. At a functional level, particularly in terms of anal tone and sphincter tone, these can influence some of their symptoms like urgency, like fecal incontinence, like disease burden in terms of symptoms. And the second factor then we have to address is some of the challenges as people get older, they have less mobility. It may be not convenient to come into infusions. They may have issues in terms of dexterity and eyesight in doing sub-Q injections. And then they may have limited social support. So if you're now dependent from driving yourself to now having someone got to drive you in for your visits, your colonoscopies, your infusions, that may make or create more challenges for them in terms of care. And there's also this concept of frailty, just of overall functional ability declining over time that can affect your ability to address your symptoms and also optimize your care. Next slide, please. So this gives you a nice example, both from the Robert case and actually from real world practice of what we see in the real world. And this is looking at 400 IBD patients over 65 from electronic health records. And they looked at what maintenance therapy were these patients on. And for me, and I hope for you, the big surprise here was a third of these patients, their maintenance therapy was prednisone. So more than 6 months of prednisone therapy, which is, shocking because we know that prednisone has so many side effects as a maintenance therapy, all of which are worse as you get older. Infections, bone loss, elevated sugars, hypertension, and so forth. And so to think that a third of these patients, that's their maintenance agent, is quite scary. And you can also see how underutilized anti-TNFs were in this paper. It's from 2012, but still 3% of patients with anti-TNFs is far lower than we see in other age groups. So you suspect there's some bias here that they're being withheld anti-TNFs because of an age reason. Next slide, please. So why might people be holding back on using more effective therapies? I guess the main one is typically concern about infections and adverse events. And also we have many patients who have a history of cancer come to see us, and the history of cancer can hold back what therapies they're given. And then certain comorbidities. In recent years, we've seen signals with embolic events with JAK inhibition. We've seen signals with cardiovascular risk with anti-IL-12/23 agents. And so these are starting to feed into how we make decisions about therapy in patients older than 60. Next slide, please. So a nice example here. This was from the TREAT registry where Gary Lichtenstein was the first author in this, looking at post-marketing surveillance of patients on Infliximab. And the big signal from this was ostensibly a study to look at safety of anti-TNFs. The big signal was actually the highest risk of infections were in patients on the two oldest agents we have, steroids and narcotics. They had a 10-fold adjusted hazard ratio of their risk of serious infections with therapy. This compared to patients on Infliximab alone or Infliximab immunomodulators, it was lower, albeit there was an increased risk, but not as high as giving patients prednisone with narcotics. And then when you start adding in multiple agents, so prednisone plus immunomodulator, plus a narcotic, and so forth, you start to get cumulative risk. And so multiple agents are greater risk of infections, but the older agents, prednisone and narcotics, were the highest risk overall for risk of infections. Next slide, please. So Jim Lewis published this very nice paper looking at 12,000 patients and looking at their maintenance therapy. So they compared patients on chronic steroid use as maintenance versus patients on anti-TNF as maintenance. And not surprising to me, and I hope not surprising to you, was actually using maintenance anti-TNF produced a lower risk of death, cardiovascular events, hip fracture, than being on maintenance prednisone. So another good reason not to be using steroids as a maintenance therapy for our elderly patients with IBD. Next slide, please. And this is a study from MGH which went a bit further. They looked at patients who were older and actually looked at patients who were high on what's called a frailty score in the months leading up to their starting therapy with either immunomodulator or anti-TNF. And the outcome they were interested in was what was the risk of infections. And what they reported was that the frail patients started with immunomodulator, or the frail patients started with anti-TNF, had at least twice the risk of infections on therapy as patients who are not frail. And this feeds into this concept that your overall functioning and frailty may be the risk factor for infections in patients who are on these immunomodulators or anti-TNFs. And so frailty is an important measure to think about. Next slide, please. So ACG now recommend that we try and really personalize therapies in this age group to what organs are involved and what the risk factors are for chronic therapy in terms of infections and adverse events in the elderly populations. And trying to use systemic therapy first before using more systemic agents that may have greater adverse events. And so this is a consideration, again, in this complex. We look at adherence, we look at sustainability, efficacy, safety, and also frailty, and particularly risk of adverse events in the elderly population. Next slide, please. So moving on to a different class, most of us would consider Vedolizumab or the anti-integrin class as a safer option, quote unquote, for our patients in general. In the randomized controlled trials, we've seen no increased risk above placebo with infections, very few cases of TB, low rates of malignancy, immunogenicity, infusion-related reactions, and no PML in those trials related to VDC. So this might seem like a great choice for someone like Robert, who has some comorbid issues, but wants an effective, safe agent to treat his ulcerative colitis with. Next slide, please. And there is some data on this. This is looking at a study of patients. I think there was 140 patients in each group, and they were looking at overall infection rates in patients who were on Vedolizumab. And they divided into patients under 40 who are quote unquote the young, and patients over 60 who were in this group the elderly. And you can see here there was numerical but not significant differences in terms of remission at week 52, but there was a higher and statistically significant rate of infections in the over 60s versus the under 40s while on Vedolizumab. Now, my interpretation of this data, this is the risk factor here is age and comorbid conditions rather than therapy, because there's no control here to say what was the infection risk in the over 60s who were on other agents for IBD. But certainly something to consider. Next slide, please. And then Ustekinumab is the other agent that we often think about in refractory UC. This is data from the phase 3 trials in ulcerative colitis looking at risk of infection, and serious adverse events. And we have the placebo group on the far left and different quartiles of levels of Ustekinumab trough level across groups. The bottom line here, all of these three outcomes were similar whether you were on placebo or different trough levels of Ustekinumab in the blood. Next slide, please. Now, recently we did see a signal, and this is of interest to the group, is looking at patients who were at a low or high cardiovascular risk in multiple trials of Ustekinumab and looking at the risk of cardiovascular events. So these cardiovascular events were acute coronary syndrome or a stroke. And the risk, if you had a cardiovascular risk factor while you were on Ustekinumab therapy, the odds ratio for adverse cardiac events, such as stroke or acute coronary syndrome, was significantly higher in those who had cardiovascular risk factors. This is more than 2 cardiovascular risk factors. So there's a signal here that certainly warrants caution in patients who have a history of cardiovascular disease or cardiovascular risk factors and considering Ustekinumab in this population. Next slide, please. And you can see here, this is just another way of showing the data, that the overall and based on exposure and dose increases, there was a higher odds ratio for severe cardiovascular events in those who had a high cardiovascular risk, but not in those who had a low cardiovascular risk. So probably worth considering someone like Robert, what are his cardiovascular risk factors when you're thinking about Ustekinumab as an agent for his ulcerative colitis. Next slide, please. So I hope that was a quick run through of a lot of data, but I think the considerations here are make sure we have effective therapies, do not be using steroids as chronic maintenance therapy, but review all the comorbidities, the polypharmacy involved to make the best choice for your patient in terms of efficacy and safety, particularly when looking at frail patients and their functional status. Back to you, Aline.
That was excellent, Alan. Thank you so much for this overview. I think it's, IBD in the elderly, you got that topic because it's a very important topic, not because you have a gray hair. And I think we only have young people with us today, whatever the age is. It's about frailty and fitness. It's about choosing the right agent depending on the our goals of care for the elderly. I think in a patient like Robert that you presented, he's very active. He's doing well. He's medically, in overall good health. It's important to remember that steroids are probably the least effective agent that we have at this point for maintenance and the most harmful. So thank you for this overview, and I'm sure we'll have more questions on that. And so next we'll move to our patient Joseph. Maia, I know you have a special focus in disorders of the pouch, so I'm very excited to hear you speak and give us your tips on how to manage antibiotic refractory pouchitis.
Great.
So this is the case of Joseph. He's a 51-year-old gentleman who was hospitalized at diagnosis for severe UC. He was giving infliximab 2 doses and without any response. So he underwent surgery with a total proctocolectomy followed by a pouch construction. He did well after surgery, but 1 year later, he comes back complaining of abdominal cramping, increase in his bowel movement, 5 above his normal, a lot of urgency, and some mild rectal bleeding. His gastroenterologist diagnosed him with pouchitis. This is one of the most common disorder of the pouch. So he was diagnosed with pouchitis and empirically treated with a course of antibiotics. Next. He doesn't do too much with antibiotics, and he comes and see you, Maia, and you perform stool studies that are negative. His CRP is slightly elevated. And on endoscopy, he has a granular erythematous and friable mucosa of the pouch, but no inflammation of the pre-pouch ileum. So I'm going to, Maia, you led a wonderful Monday Night AbbVie conversation on managing one of the disorder of the pouch and the patient with more Crohn-like disease of the pouch. Laura Rafael and Florian Reiter also led a great conversation on pouchitis and really different clinical scenario that led us to different management strategy and different diagnosis possibility when we're dealing with antibiotic refractory pouchitis, anywhere from Crohn's-like disease to colitis to PSC-associated pouchitis. And depending on the scenario and the finding, different approaches were recommended by our Monday Night AbbVie community. So I'm going to hand it back to you and tell us how to approach a patient with pouchitis and how to approach a patient with antibiotic refractory pouchitis.
Great. As you said, this is a topic that's very near and dear to my heart. I'm especially interested in our pouch patients. And I think to start off, it's really important to establish what's normal in a pouch patient. So, and this goes back to kind of pre-colectomy counseling and informing patient what their new normal will be after they have a pouch. So what we inform our patients is that, typical bowel movement after a pouch is 6 to 8 during the day. Bowel movements are typically soft, porridge-like. They're not going to have those kind of firm stool bowel movements that they were having pre-colectomy or pre-disease, I should say. And what we expect is our patients to really have good quality of life, have continence, have 6 to 8 soft bowel movements during the day. We don't want them waking up at night, but 1 to 2 nocturnal awakenings is within the normal range. The most important thing when we see these patients and they're complaining of symptoms or frequency or urgency is to realize that not all disorders of the pouch are pouchitis. A detailed history and physical is key to understanding exactly what's going on with your pouch patient, in addition to performing a pouchoscopy and basic labs, and then considering additional studies like imaging or manometry. Timing is very important in these patients. So any disorders that occur less than 12 months after surgery really should be considered to be within the realm of a surgical complication or surgical issue. So these include anastomotic leaks, pelvic sepsis, fistulae, or strictures. In this situation, it's really important to not then commit the patient to medical therapy, but really work hand in hand with your colorectal surgery colleagues to understand more about what's going on. Functional disorders also occur commonly in the pouch. These include pouch evacuation disorders such as dysenergic evacuation, decreased pouch compliance, irritable pouch syndrome, which presents very similar to irritable bowel syndrome. And then kind of the most common complications that we see a year out for pouch patients are inflammatory disorders, which include pouchitis that can either be due to infection, C. diff or CMV, NSAID-related pouchitis, autoimmune pouchitis in patients who have PSC, Crohn's disease-like pouch inflammation, which is a condition that I think we're recognizing more and more as we're defining it better, but then also cuffitis in patients who have a stapled anastomosis and have a remnant rectal cuff, and then also ischemic pouchitis. So during a pouchoscopy, it's really important to closely evaluate each anatomical segment with close attention to the pre-pouch ileum, also known as the afferent limb, also known as the inflow tract, paying very close attention to the inlet, the pouch body, the tip of the J pouch, the cuff, and the anastomosis. Now, we have 2 scoring systems that have been developed to diagnose pouchitis and assess the disease severity. The Pouchitis Disease Activity Index is shown here. We also have the Pouchitis Activity Score, and both use a combination of clinical symptoms, endoscopic findings, and histologic features. So the PDAI is shown here, and it takes into account such clinical features as frequency, rectal bleeding, urgency, fever. Takes also into account endoscopic findings that can be difficult to objectively measure, such as granularity and friability and edema, but then also erythema, ulcers, and erosions. And then it also includes histologic features such as polymorphonuclear infiltration and ulceration. We typically score patients, or we typically consider patients to have pouchitis if they have a total PDAI score of greater than 7. So there are many risk factors for diseases of the pouch that have been reported in the literature. Individual risk factors for kind of acute antibiotic responsive pouchitis or refractory pouchitis include having a history of extensive ulcerative colitis before colectomy, having extraintestinal manifestations of UC, especially PSC, having concurrent autoimmune diseases, requiring or using a lot of NSAID use, having a history of never smoking. I don't think that really would encourage us to tell our patients to smoke, but having that history of not smoking does increase the risk of pouchitis. But then on the flip side, having active smoking also increases the risk of Crohn's disease-like pouch inflammation. Patients who are at a younger age at the time of their colectomy and pouch creation have an increased risk of cuffitis. And then patients who have comorbid psychiatric conditions and are on antidepressants or anxiolytics also have a risk for irritable pouch syndrome. So the pathogenesis of idiopathic pouchitis is pretty unclear, but it's thought to involve a complex interaction between the microbiome and the immune system in genetically susceptible patients, which if you think about it is the same kind of pathogenesis that we think is related to Crohn's and colitis. In the pouch, you have fecal stasis because of the altered bowel anatomy that occurs when you construct the pouch, and this promotes variation of commensal bacteria or dysbiosis. Dysbiosis and exposure to an increased microbial load promotes colonic metaplasia of the ileal mucosa, which then activates the mucosal immune system. And we know that both of these, the microbiome and the mucosal immune system, are altered in patients who have pouchitis compared to patients who have a healthy pouch. So the bottom line is that clearly dysbiosis is driving the pouchitis process. So the treatment of pouchitis is then based on this theory of dysbiosis. And antibiotics are really first line for the treatment of pouchitis, and ciprofloxacin or metronidazole are the antibiotics of choice. So interestingly enough, there's really only been one randomized controlled trial that compared ciprofloxacin to metronidazole for acute pouchitis. And it was small with only about 19 patients, but it showed significantly greater decrease in the PDAI score and less adverse events with cipro. Alternative antibiotic regimens like augmentin, rifaximin, beta-lactams have really quite limited evidence. However, we know from anecdotal evidence that patients do respond quite well to rifaximin. There is not great evidence for probiotics in maintaining remission, although lots of patients are interested in starting them and in continuing them. I think the issue with probiotics often is cost, but again, there's not great evidence to maintain remission in patients who have recurrent or antibiotic-dependent pouchitis. FMT data, while it's trendy and it's interesting and everybody kind of wants to get on that train, it's just not robust enough to make a recommendation for patients who have pouchitis. A review that we had conducted did show that it was safe, but not quite effective. Now, there's a lot of, up-and-coming trials in FMT for pouchitis, and so we're really excited to see the results of those soon. So what's interesting is, what exactly are antibiotics doing in the pouch? We know that patients respond to antibiotics, and we know that the pouch responds to antibiotics because, again, patients feel better when they're on it, so we know they're doing something. So this was a very interesting study that was led by Dr. Aristoton that looked exactly at what antibiotics are doing in the pouch. So antibiotic treatment reduced disease-associated bacteria, but then it also reduced beneficial bacteria and diversity. And we had mentioned that diversity is important in the pouch because decreased diversity is associated with pouchitis. But what's interesting is that antibiotics also reduced fecal calpro and flare symptoms. So it seems what antibiotics are really doing is they're reducing bad bacteria and good bacteria, but they're creating this new microbiome that's antibiotic resistant that has a low inflammatory potential. So this microbiome might provide resistance against colonization that promote inflammation. So essentially you're kind of manipulating the microbiome with the pouch by reducing diversity, but then also reducing kind of the bacteria that could promote inflammatory complications. So it's, I think up-and-coming studies are being reported soon about what other effects of antibiotics are on the pouch, but this was exciting to show us that maybe by reducing bacteria that have an inflammatory potential, you're altering the risk of pouchitis. So we can actually further subclassify the spectrum of idiopathic pouchitis dependent on its response to antibiotics. So as we talked about, the majority of patients fall into the category of acute antibiotic responsive pouchitis, but then up to 20% of patients will develop chronic pouchitis that is either antibiotic dependent or refractory. And those with antibiotic dependent pouchitis respond to antibiotics, but they have frequent relapses if antibiotics are withdrawn. And the treatment options for these patients include prolonged courses of low-dose antibiotics or alternating antibiotic regimens that minimize the risk of antibiotic resistance. You have a class of patients who have antibiotic refractory pouchitis, and these patients have persistent symptoms and objective inflammation of pouchoscopy despite adequate antibiotic courses. And in these patients, secondary courses or secondary causes of pouchitis really need to be ruled out, like ischemia, autoimmune disease, and infection. Once these secondary causes are excluded, the treatment often becomes biologics, which is what we'll go into in the next couple of slides. So treatment of chronic antibiotic refractory pouchitis is difficult, and unfortunately, there's no randomized controlled guidance to support any of our decisions. Steroid therapy with budesonide has been tried in multiple small studies with remission rates of 60 to 75%. And remission here, again, no great definition. It's typically defined as a composite decrease in clinical, endoscopic, and histologic findings. There's little data to support the use of immunomodulator monotherapy for antibiotic refractory pouchitis. There was an interesting prospective pilot study in Japan where 10 patients were treated with tacrolimus enema and noted a remission rate of 90% based on a decreased composite PDAI score of less than 4. This is certainly interesting. Unfortunately, there's been no other studies that have looked at immunomodulator monotherapy for these patients. And there's been multiple observational studies that have described some benefit with biologics, specifically infliximab, vedolizumab, and ustekinumab. Now, unfortunately, these are, again, mostly observational studies, retrospective data, but the remission rates range from 30 to 60%. And we'll go into kind of each one of these classes. So TNF has been studied, again, retrospectively in an observational way for chronic antibiotic refractory pouchitis. And in this very nice systematic review with meta-analysis of the use of TNF therapy in refractory pouchitis, but then also Crohn's disease-like pouch inflammation, the authors identified 21 articles and 3 abstracts that included 313 patients who were treated with either infliximab or adalimumab. The rates of short-term and long-term clinical remission were 50% and 52% respectively, which is pretty good. Now, the rate of remission after anti-TNF induction therapy in this study seemed to be higher in patients who had Crohn's disease-like pouch inflammation compared to refractory pouchitis, which is interesting and lets us know that maybe we can extrapolate data from the Crohn's disease population to patients who have Crohn's disease-like pouch inflammation of the pouch. Now, something that is an important question is, can patients who were treated with anti-TNF therapy before their colectomy, can they be treated again with anti-TNF therapy for chronic antibiotic refractory pouchitis? Again, no sound guidelines or guidance on this. Our institution had actually looked at this specifically about whether or not we could recycle pre-colectomy anti-tumor necrosis factor agents for patients who have chronic pouch inflammation. And what we found was that this was actually associated with treatment failure. So using the same anti-TNF pre-colectomy for their colitis, then using it again for their chronic pouch inflammation was associated with treatment failure, increased risk of a pouch excision, and a need for an ileostomy. So that allows us to consider that maybe considering a switch of class to either ustekinumab or vedolizumab would be a good option. And so kind of what is the data for vedolizumab in CARP? It has been looked at. This was a multi-center study in the United States that looked at 83 patients who were treated with vedolizumab for inflammation of the pouch. And this included patients with chronic pouchitis, but then also Crohn's disease-like pouch inflammation. The median follow-up was 1.3 years. And the proportion of patients that achieved at least a clinical response was approximately 40% at 3 months, 43% at 6 months, 28% at 12 months. The rates of remission were lower, ranging anywhere between 12 and 19%. Of the 74 patients who had follow-up pouchoscopy, the proportion of patients who had endoscopic response and mucosal healing was 54% and 17%. So unfortunately, we don't know that can we achieve mucosal healing in these patients? And that definition, again, is still very vague, but we typically use an understanding of whether ulcers are still present or are no longer present after the use of a biologic. So again, we don't have great rates, but for now, until we have more prospective data, this is all we have. And what's interesting in this study is that patients who develop pouchitis symptoms less than 1 year after having their pouch were less likely to respond to vedolizumab, even after controlling for other risk factors, which to me suggests that maybe these patients have a very aggressive form of disease that might not respond to any biologic. So ustekinumab was also looked at for the treatment of CARP. And then this single center study, 24 patients with CARP were included for analysis. The median follow-up here was 12.9 months. 12 patients, about 50%, had a clinical response, with the median number of bowel movements within 24 hours decreasing from 8 to 6. 13 patients had pouchoscopies available after the initiation of ustekinumab. And in these patients, the median endoscopic subscore of the PDAI decreased from 5 to 4. Likewise, among these 13 patients, 9 had an ulcerated surface that was greater than 10% before ustekinumab treatment. And then after ustekinumab treatment, only 31% of patients still had that ulcerated surface area. So again, since we don't have a great scoring system, using the idea of how much of the surface is ulcerated, how much of the pouch is involved, whether the inflow tract is involved, pouch body, or both are involved, is key to kind of understanding in an individualized way how your patient is responding to these drugs. And in this study, of those patients who had Crohn's disease or Crohn's disease-like pouch inflammation, a higher BMI at the start of therapy and male sex were both predictors of non-response to ustekinumab at 6 months. the bottom line is that Ustekinumab did lead to improvement of clinical and endoscopic endpoints, as did Vedolizumab in the study that we looked at before, as did anti-TNF therapy. The rates aren't great, anywhere from 30 to 60%, but still good. And for patients who you don't want to keep on antibiotics for a long term and who are not responding to antibiotics for a long term, the increased, the efficacy and the favorable safety profiles of Vedolizumab and Ustekinumab certainly make them as good treatment options.
This was fantastic. Thank you, Maya. This is a nice algorithm that actually it's a Twitter to paper algorithm where we had a conversation on Monday Night IBD, and then we published the paper in the IBD journal Open Access CC 360, which, like Alan says, is the cool people journal. And this was our algorithm where, when we have a patient with Pouchitis, if they respond to antibiotic, do the courses of antibiotic as needed, as long as there's no side effect. And if patients who are more antibiotic dependent, where every time you stop antibiotic, they have symptoms again, maybe rotate in between antibiotic or use non-absorbable antibiotic or use the lowest effective dose of antibiotic. And in those who are antibiotic refractory pouchitis or who have non-idiopathic pouchitis, including Crohn's-like disease of the pouch, then consider more the biologic. And before we leave the slide, Maya, there's a question that came on the Facebook feed of our live webinar. Two questions. One is, when you have a patient presenting with pouchitis symptoms the first time, and knowing that pouchitis is the most common pouch disorder, can we start the patient empirically on antibiotic, or do we need to do a pouch exam first? Do you start antibiotic and do the pouch exam? Do you wait for the pouch exam, or do you wait to see a response to antibiotics? And in those that are have more of antibiotic dependent pouchitis, do you favor in your practice, or how do you see your patient preference is in either being on a low dose antibiotic chronically, knowing that medication like Cipro, there's a black box about ruptures of tendons, etc., or would you then attempt to use one of the biologics you mentioned today?
So those are two great questions that I think are very relevant to clinical practice and come up quite often in our IBD center. So the first question of if a patient is coming in with symptoms of pouchitis, I do often do a pouchoscopy, and I think it's important to establish that diagnosis before you start treatment. Now, I think limitations of time of pouchoscopy, availability of an endospot, availability of the patient to come in for a procedure certainly limit the ability to do a pouchoscopy. In an ideal situation, before I start antibiotics, I would do a pouchoscopy, establish the disease, look at the landmarks, the anatomical segments of the pouch, and really document clearly that this is pouchitis with ulcers, erosions of the pouch body. The situation of, would I start antibiotics before I do the pouchoscopy? Would I do the pouchoscopy a couple of days after they've been on antibiotics? I think realistically, yes, I still want a pouchoscopy at that first event of symptoms. As I had mentioned, I think history is so important for our pouch patients, and a lot of them might be misdiagnosed with chronic antibiotic refractory or Crohn's disease-like pouch inflammation without a clear baseline exam. And so I typically advocate for pouchoscopy, as do many of my colleagues in our IBD center, at baseline, first symptom development. I wouldn't necessarily defer treatment for 2 or 3 weeks until I can get them in for a scope. What I typically do is I prescribe, antibiotics the minute they tell me, but then I try to get them in for a scope within 2 to 3 days. And I think that's still kind of valid, because while I'd mentioned that there's really been only one randomized controlled trial looking at the efficacy of antibiotics in pouch, we don't actually know what antibiotics do to the mucosa and whether or not you achieve mucosal healing and healing of the ulcers with just antibiotics. And so because of that, I think it's okay to kind of start antibiotics and try to get your patient in for a pouchoscopy within a couple of days to then establish that baseline. Because again, it seems like antibiotics, it's the manipulation of the microbiome that patients are responding to, and maybe not necessarily healing of the mucosa quite yet, but I do always want that baseline scope. And then in response to the second question, I really don't like antibiotics. And I think in patients who are responding to antibiotics, it's wonderful, but then, committing them to a lifelong course of something like Cipro, as you mentioned, it has a lot of tendon, adverse effects, and there's a black box warning. But then even something like Flagyl, which we know causes nausea and has neuropathy issues, and I just don't want to commit patients to a lifelong course. So I have a very honest and clear conversation with my patients, and I say, you're responding to these medications. Every time we try to bring you off, you redevelop symptoms. It's certainly not a long-term maintenance option, in my opinion. And I know everybody has kind of their own ideas about this. So I do advocate the use, the early use of some of our newer medications like Ustekinumab and Vedolizumab. And I think that's warranted because the safety profile is good for these drugs. And again, with Ustekinumab, you have the ease of use. You have the Q8-week dosing where patients can kind of administer at home. With Vedolizumab, you also have, the Q8-week dosing. It might be a bit not as easy to use since they are tied to an infusion center. But I do think that getting patients off antibiotics is key. Rifaximin is a good option. It's non-absorbable. Patients do respond well. Again, it has to do with the manipulation of the microbiome, but it's expensive. And again, committing patients to kind of lifelong antibiotic, it's not something that I enjoy doing, and not something that I advocate for. But I think the opinions on this, vary widely. So at least this is what I typically do.
Discussions, but it's thank you for your input and your expertise on that. So we can go to the next slide. But before we conclude, can we have Dr. Moss, Alan back on, because we have another question on Twitter, and I know, Alan, you were multitasking and answering the questions live, but I thought it would be helpful for everyone to hear it, because that's the question that often comes up. So in our earlier case that we discussed, if you plan to optimize your infliximab, if a patient is on infliximab doing well and then start losing response because of a low drug level and some antibodies, and we talked about dose escalating. So the question is, do you increase the frequency and the dose? Do you add an immunomodulator? Do you do everything? And when do you reassess? When do you recheck drug level and antibodies? When do you reassess the patient clinical symptoms? When do you expect them to be better with the measures that we've done? Do you add a steroid course to that? So many questions for you, Alan, before we conclude.
Sure. Thanks, Elaine. So I think if we decide we're going to try and stick with infliximab in this case and optimize it, we know two things, and most of this is from case series. We know that moving to a shorter duration between infusions is better than doing a high dose at the same 8-week interval. And the PK data all shows that you'll get a better steady state of level. So in someone like her, we'd make a decision, okay, we're going to go from Q8 weeks to maybe, let's say, Q6 weeks initially. I would also suggest that increasing that first dose to try and overcome this low trough and these ATIs is going to be a way to go. Adding an immunomodulator would also make sense in terms of driving down ATIs, since we now know she makes ATIs, right? The question is, do you give her prednisone before that first infusion? In my mind, I don't think it makes any difference. I think that's going to prevent the issue. I think it's the subsequent infusion where you start getting concerned about a higher risk of infusion reactions. But we do know that if you can get the trough high or add an immunomodulator, you can drive down those ATIs. Again, case series observational data. But that's how I would approach it. So more frequent interval, shorter interval, higher dose initially, and then you want to get to steady state. So you do 2, maybe 3 infusions at that interval and higher dose, and then you recheck levels, recheck ATIs. If you're driving down the ATIs and you're getting the trough to the 10 range, we think you're going to get mucosal healing, and we think you can actually sustain that. Now, if at the second, third infusion, you still have ATIs in that range, that's where I suspect we're not going to overcome this. And we know from meta-analysis that the risk of the patient failing therapy remain high, and that's why I start to consider cycling off to something else.
All right, thank you, Alan. That was very helpful. This is a question that often comes up, so thank you for your input. I think we're running out of time, and if we didn't get questions, we'll get it on Twitter, on Facebook. I think we're going to conclude our program today. Alan and Maia, I want to thank you for joining me. That was a fantastic session. I learned so much from both of you, and I know it's been helpful for many people. I really enjoyed my morning with you and my morning coffee with you. So in summary, what we tried to do today is really highlight the fact that advances in medical therapy have enabled us to target a better outcome for patients with UC in terms of improving their quality of life, improving their the disease outcome, preventing complication. And the fact that we have different mechanisms of action that have different efficacy and safety and targets really give us different tools so we can personalize and individualize our care to our patient with ulcerative colitis and promote the best outcome. Please join us next week where we're going to talk more about the importance of mucosal or histologic healing and how to also stratify our therapies, and we'll talk also about new and emerging therapies in ulcerative colitis. Thank you for spending the morning with us, and thank you for your support and being part of the wonderful Monday Night IBD community. Maia and Alan, thank you again for joining me this morning.